Hello everyone, my name is Ahmed Kotb. Squint and pediatric specialist in National Eye Center of Rudolf Farag. I will talk today about think twice, better you know before you go. What is called, we will see now. This is a child aged 10 years old, comes to me as referral for glasses and follow-up of hypermetropic esotropia. This is the pre and post cycloplegic refraction of this patient, which shows that accommodative spasm which relieved with cycloplegia. So thinking twice, I take these steps, revise, rethink, and refresh. What is revised? I revised the whole case again. First, I start with the complaint of the patient was inward deviation for 6 months, was intermittent, then became constant for the last month, with headache for 1 month, but no diplopia. Okay, the examination was visual acuity incorrectly 6-9 bilateral, pupil round regular reactive with no anisocoria, no rapid, but color vision anterior segment was totally free. The motility was concomitant constant esotropia with limited abduction bilateral, but without nystagmus. The angle in far 45 breaths and in near 30 breaths. And this picture showing the motility of the patient, as we see here in the primary position, there is esotropia with limited abduction in the right gaze and left gaze. Okay, did I finish? Wait, still there's more. When I dilate this patient and see the fundus, I see this picture bilateral. Bilateral disc edema. Can we call it papilledema? So I asked about head trauma, any systemic disease, any past history of systemic disease or family history of systemic disease, past history of surgery or glasses for this patient, but all were negative. So I think about differential diagnosis of this case, which was limited abduction with esotropia. First thing is Duane retraction syndrome with esotropia. I have globe retraction with narrowing of the eyelid. If infantile esotropia, I have the limited abduction will improve with Doll's head maneuver and may accompany by inferior oblique overaction and nystagmus. Spasm of near reflex, I have the triad of convergent squint, accommodative spasm, and meiosis. Thyroid eye disease, I will have the high level of thyroid function and may accompany by proptosis. Medial orbital trauma, I have a history of trauma with orbital fracture with muscle swelling. Myasthenia gravis, episodic muscle weakness, which is characterized by increased with fatigability and may accompany by ptosis. Finally, abducent nerve palsy, sixth cranial nerve, esotropia more than far, and the limited abduction, not passing band line. Okay. To reach my diagnosis, I prefer to ask for MRI brain, and this is the picture. A hematoma in the brain as a space-occupying lesion. This is my attitude in the clinic after I see the MRI and the fundus examination. So I rethink again about this case and mention the red flags, multiple red flags in this case, which is recent onset of limited abduction with esotropia. The angle was in far more than near, the refraction not high hypermetropic and not anisometropia. And the fundus showing papilledema with hematoma and MRI. So I refresh my diagnosis again from hypermetropic esotropia and think about false localizing sign, which is abducent nerve palsy, sixth cranial nerve. Finally, they remember a head trauma 1 year ago during playing football with no any history of headache, lost consciousness or disturbed conscious level, or nausea or vomiting at time of trauma. So I referred him to neurosurgery, and neurosurgery recommend evacuation, and this is the picture of the scan before and after 1 month, which shows some sort of resolution or resolving the hematoma. As a squint ophthalmologist, what is my rule in this case? Did I need to intervene? I preferred to follow up him for 6 months at least, but he didn't give me a chance. After 3 months, he became orthotropic again. What happened in this case? Before we talk about what happened in this case, we must talk about abducent nerve palsy, sixth cranial nerve, which comes from the bones, from the abducent nucleus and runs along bone to medullary junction and turn over the petrous tip and enter the cavernous sinus with an internal carotid artery, and then finally reach its final destination to the lateral rectus through superior orbital fissure. Parts of the sixth nerve, it brainstem, basilar, intercavernous, interorbital, causes congenital or acquired, congenital rare, and maybe spontaneously resolve in the first week of life. Acquired traumatic tumor infection or idiopathic. Symptoms and signs as sixth nerve supplying the lateral rectus, It gives esotropia with limited abduction at the same site. When to intervene in these cases, if we have diplopia, batching or prism or botulinum toxins, long-standing esotropia more than 6 months, surgical intervention according to lateral rectus function. So let's talk again about what happened in this case and why we call it false localizing sign. As the sixth nerve turns over the petrous tip, when the increased intracranial tension pushes the sixth cranial nerve against the petrous tip to give a rise to symptoms and signs of its palsy. So site of injury in this case is basilar. Always consider double pathology. Normal visual examination is not an exclusion of existing pathology. Be safe and be common. Fundus examination is mandatory even in squint, even you found the cause like hypermetropic refraction. Think twice, revise, rethink, refresh. You have the power to save a life. Don't lose it. Thank you.